Welcome to the Clinical Education Academy. I'm Salah Abbas. I'm Associate Professor of Surgery. I specialize in general surgery, and in fact, I do hepatobiliary and pancreatic surgery alongside with general surgery. So I would encourage you to interact with us and send us your comments or subscribe as well to our channel so we can give you more presentations. This is aimed mainly at medical school students, and we will try and keep it as simple as possible and as manageable as possible. So today we are talking about small bowel obstruction, and we will take you through the management and presentation and causes of small bowel obstruction, and basically how to deal with the whole problem when you get someone with suspected small bowel obstruction. Now we need to know the causes of small bowel obstruction. In general, this particular problem is relatively common after abdominal surgery, as we heal after any form of abdominal surgeries, such as bowel resection or gastrectomy or even appendicectomy. The process of healing leads to formation of scar tissue, and scar tissue can lead to a generation of bands that could lead to small bowel obstruction. The most vulnerable patients to that are those who have an operation that would disrupt the pelvic peritoneal covering, and that would be in the form of either pelvic surgery such as hysterectomy or in particular left hemi colectomy. But it could happen after any abdominal surgery. Obviously, laparoscopic surgery is less a risk to develop small bowel obstruction than open surgery, but it can happen regardless. It also could happen in people who had no previous abdominal surgery. So the causes of the small bowel obstruction are mainly adhesions, and that can lead to partial narrowing of the small bowel obstruction or complete blockage by volvulus around a band, or via an internal hernia as a result of the obstruction being, as a result of the adhesion band being attached from one point to another. Other than abdominal surgery and adhesions, we have other reasons, and these are mainly hernias. And that could be a hernia of any type. This could be inguinal or femoral hernia, ventral hernias or incisional hernias after abdominal surgery, paraumbilical hernias, and port site hernia from laparoscopic surgery. All comes under hernias that could lead to small bowel obstruction. Neoplastic lesions in the small bowel could present as the first presentation to it, usually in the form of small bowel obstruction. And these will be mainly in the form of lymphoma or neuroendocrine tumor of the small intestine that is more prevalent in the terminal ileum. And also it could be as a malignant deposit from cancer of other organs that lead to peritoneal metastases, whether that's caused by abdominal malignancy or extra-abdominal malignancy such as lung cancer or breast cancer. These are all possibilities. Occasionally, inflammatory bowel disease in the form of Crohn's disease could present in the first time or later in subsequent phases. During the treatment of the patient, they could develop small bowel obstruction as a result of inflammatory stricturing and narrowing of the lumen of the intestine. There are other reasons, such as intussusception, that could usually occur in children as an idiopathic problem, but it could happen in adult patients with small bowel benign lesions or neuroendocrine tumor that could be the lead point of the intussusception. There are other causes that you will hear about, such as gallstonitis. And gallstonitis is a term given to a patient who develop a fistula between the duodenum and the gallbladder as a result of recurrent attacks of cholecystitis and pericholecystic abscess formation, where the gallstone that is usually 2 centimeters or bigger could erode into the into the duodenum and then get lodged and block usually the terminal ileum. Now, when you hear about the term gallstone-itis, it is a disease that usually happens in elderly ladies with or elderly gentlemen with a long term of gallstone disease that is untreated, who usually had no previous abdominal surgery and present with small bowel obstruction and a virgin abdomen. Other reasons, such as anastomotic stricture as a result of previous surgery, such as ileocolic anastomosis or an enteric anastomosis between 2 loops of small bowel. Other things like radiation enteritis. Small intestine is very sensitive to radiation, but patients who get radiation, particularly to the pelvic organs for previous cancer of the pelvic organs, such as cervical cancer or prostate cancer, they could develop radiation enteritis, and that typically presents years and years after the dose of the radiation. And the reason is that it's a vascular problem that develop along a period of time. Now we will shed some lights on adhesions and why do we get adhesions. Obviously, as we said, this is a result of a previous abdominal surgery. Surgical trauma to the peritoneal cavity will heal by scar formation. Previous intra-abdominal sepsis, and these could be in the form of previous medically treated or subclinical appendicitis or diverticulitis that's usually treated with antibiotics and settled down, or as a result of post-operative bleeding. Blood is returned to the peritoneal cavity, and also the fibrin that results from blood clotting and formation of fibrinogen is a strong initiator of the process of adhesions. We know that pelvic surgery is particularly notorious for small bowel obstruction as a cause. Also total colectomy, because these will lead to extensive scarring in the abdominal cavity. Any intra-abdominal sepsis, such as a pelvic abscess from PID or from diverticulitis or appendicitis, could lead to formation of adhesion, and that could present either at the same time of the intra-abdominal abscess presentation, or later on it can present as small bowel obstruction. Now, metastatic tumors, the most common are the colonic, gastric, ovarian cancers, and pancreatic cancers. Outside the abdominal cavity, it's either lung or breast cancer that would metastasize to the peritoneal cavity. It is of significant importance to us to know that sometimes we get a closed loop obstruction. And as I can show you here, you see that the bowel gets blocked at 2 points where a loop will become completely entrapped by the adhesions, and that as a surgical emergency, usually this does not rectify itself without surgery, and we will elaborate on that a bit later. We will need to understand the pathophysiology of the patient. What does actually happen to them? Now we know the causes and what causes the adhesion. If someone develops small bowel obstruction, we need to know the systemic changes. What will happen to the patient? As a result of the blockage, there will be excessive peristalsis. And the peristalsis eventually will give up to fatigue and dilatation of the small bowel, and that will lead to sequestration of a significant amount of water and electrolytes that will accumulate in the lumen of the small bowel or in the wall that lead to edema and thickening of the small bowel wall. This phenomena is called third spacing, and it's known in more so obviously in patients who have sepsis or multiple organ failure, but it does start within a matter of a few hours after the start of the symptoms of the patient and small bowel obstruction as well. Patients who have small bowel obstruction that's localized to the upper jejunum, proximal bowel obstruction, they do have excessive vomiting. There will be minimal abdominal distension, but they will develop hypokalemia and also hypochloremia as a result of loss of hydrochloric acid and potassium from the vomit. And these are produced obviously by the stomach, which will lead to metabolic alkalosis. Distal obstruction obviously will lead to more dilatation and more third spacing than proximal small bowel obstruction. So there is this bit of change in pathophysiology that will be different in these two cases, which is important to keep in mind. As a result of that, we get what's called acute kidney injury, and that's caused by the fluid shift and the hemodynamic changes that will occur. So the patient will have rising creatinine and reduced EGFR, the glomerular filtration rate, when you check their renal function on their blood test. As a result of the increased abdominal distension, we will have increasing intra-abdominal pressure, which will have a negative impact on respiration as well. In patients with a small bowel obstruction, what will happen is that you will get rapid growth of bacteria. There will be accelerated growth of bacteria, which is bacterial overgrowth, and that will have some implications because of the possibility of bacterial translocation and the eventual risk of having sepsis in these patients. Now we understand the pathophysiologic impact of the small bowel obstruction. We'll move on to the clinical side of things. How do these patients present? They present with abdominal pain of a sudden onset. Pain is central, usually around the umbilical region, and it's colicky and intermittent. That will be associated almost certainly with nausea and variable degree of vomiting. When you examine them, there is also abdominal distension that could be obvious, particularly in thin patients. It might be more challenging in obese patients. They will obviously suffer from obstipation, which is passing no wind or bowel motions. One of the things that we notice in early stages of small bowel obstruction, patients could get diarrhea, and or they report they had some form of diarrhea, which is in fact a false clinical diagnosis of diarrhea, and that happened because of the increased peristalsis of the intestine. As a result of that, the distal small bowel and the colon motility will increase, which will lead to frequent loose bowel motions, and then they will go into the mode of obstipation following that, which is a matter of few hours. We need to take notice of the content of the vomit. Upper GI obstructions lead to biliary vomiting, and on insertion of the nasogastric tube, the contents will be bilious. While those who have distal small bowel obstruction, you will notice that their vomiting and the content in the nasogastric aspiration tube is feculent, and that will happen after a few hours, and this is mainly due to bacterial overgrowth. Now, if we go to the patient and we think because of their clinical presentation and their past history of surgery, we will need to conduct the initial evaluation. Over the years, abdominal X-ray has been the gold standard, and with the small bowel obstruction, you see that typical stepwise layered pattern of dilated small bowel with what we call valvulae conventis. The dilated loops are central in the central part of the abdomen, which in contrast to the large bowel obstruction, which tend to be on the periphery or a picture frame side of the abdomen that will have dilated loops. Increasingly and almost these days, always patients will get a CT scan, and that will be useful for evaluation of these patients for a variety of reasons, particularly if they had cancer history in the past to rule out recurrence. And also it will diagnose the site of the small bowel obstruction, and it will show us certain signs if there is volvulus or vascular compromise of the small intestine. Once you secure the diagnosis, you put a nasogastric tube, you notice the quantity and the quality of, or the color of the fluid that you have aspirated from the stomach. They will need aggressive fluid resuscitation, particularly those who you find they have long duration of symptoms or when there is evidence of acute kidney injury. Pain control, that's obvious. Electrolyte correction is very important in this situation. Every patient with a small bowel obstruction, as a rule, should have a urine catheter, and on a clinical examination, don't forget to check them for hernias, particularly groin hernias in elderly women. And if they have no previous abdominal surgery, in this particular subset of elderly women, think about gallstoneillus and femoral hernia. It's always very exciting to make the diagnosis on clinical grounds, and then that can be confirmed by imaging. One of the major issues in small bowel obstruction is that the method of the management will really depend on the type of the small bowel obstruction, and that could be arbitrarily divided into a strangulated and simple small bowel obstruction. We would have to look for signs of strangulation, and clinically you'll find the patient will have the pain localized to one part of the abdomen, and instead of starting and being colicky later on after a few hours, the pain will be almost always continuous, and they will have localized tenderness in certain part of their abdomen. If they don't have strangulation, usually the abdomen, despite the fact it's distended, there will be no tenderness. So if you see tenderness or the pain is beyond control, think about strangulation of the small bowel. White cell count will be elevated, and when you do a CT scan, there is what we call the tornado sign. And the tornado sign is a CT sign of volvulus of part of the small bowel, where the blood vessels seem to have been twisted like a tornado. These patients almost always look unwell, and you need to keep an eye on that, because if you think, and if it is confirmed, or there is high suspicion of strangulation, these patients will need a laparotomy to sort out the problem. Otherwise, they will not settle down. Other signs that can be useful from the CT scan is what we call nematosis, which is uh, the presence of gas loculi in the wall of the small bowel. It is usually a sign of long-standing small bowel obstruction that has been there for days, and there's pockets of gas in the wall of the small intestine as a result of the translocation of the gas from the lumen to the wall by probably either bacterial overgrowth or uh, mucosal ulceration, or usually both. Rarely you could see portal venous gas. That's gas that would be seen in the superior mesenteric or the portal vein on CT scan. Now, how do we manage them? If we think the small bowel obstruction is simple and there is no evidence of strangulation and no clinical concern about strangulation, then we manage that with non-operative measures. We've already put a nasogastric tube and started the intravenous fluid, and we've got the stomach emptied, hopefully, and it's very important to put a 14 French nasogastric tube. What I recommend patients, particularly who are elderly, if they vomit, they are at a significant risk of aspiration, which can lead to bad consequences. Once we empty their stomach, we give them 100 ml of gastrografin, and that will be put via the nasogastric tube. We spigot the nasogastric tube for a few hours, and the minimal that I recommend is 2 hours. And then I get an abdominal X-ray for them about 6 to 8 hours. Now, gastrografin in this situation will work as a diagnostic tool as well as a therapeutic tool. So as a diagnostic tool, it works, the rule goes like the following. If the gastrografin is seen in the colon after 6 to 8 hours with the plain abdominal film, it means that the small bowel obstruction is simple, is partial, and it's 95% of the time it's likely to settle down with non-operative measures. Also, it has got a therapeutic role. Gastrografin is hyperosmolar, so it helps to suck the edema out of the small bowel wall and enhances its contractility and works in a way as a laxative, which will help them to resolve and probably shorten their hospital stay as well. Now, majority of people with a small bowel obstruction, and we say it's nearly 70%, will settle on these conservative measures. But if the gastrografin is not in the colon after 6 to 8 hours X-ray, or there are other problems, then we have to proceed for a laparotomy. Now, an important topic is small bowel obstruction in a virgin abdomen. Now, majority of them, 55% of them, the blockage is related to band adhesion. And that's, like I mentioned before, either previous diverticulitis or previous appendicitis that has been treated medically, or pelvic inflammatory disease in females. The rest of them are caused by tumors. And the tumors, like we have mentioned earlier before as well, they're either lymphoma, neuroendocrine tumor, metastases, or it's if we have colon cancer of the right colon with incompetent ileocecal valve, it could present as small bowel obstruction. Now, CT scan will be crucial in this situation, and it will help us to decide, because if the obstruction is related to any one of these reasons, then we need to proceed for a laparotomy. Now, often people ask about the role of laparoscopy in this situation. Do we employ laparoscopic surgery with a small bowel obstruction, particularly if it's related to adhesions? We do on occasional basis, and that will happen in the following situations. You need to have a mild distension because you need to have enough room, enough space to inflate the abdomen with CO2 to be able to have adequate, safe visibility. That could happen either in proximal small bowel obstruction, or the obstruction is partial, or if we on a clinical ground and experience basis, we think this might be just a single band, then laparoscopy could have a role. Otherwise, if surgery is indicated, it will be in the form of laparotomy. Thank you much for that. I hope that I have covered the bases that will help you to manage people with a small bowel obstruction. And please leave your comments for us. And if you have any queries or any suggestions, I will be more than happy to consider doing a presentation on anything you feel will be useful. Thank you, and I'll see you the next time.